Thanks for listening to this talk on abdominal imaging in ICU as part of the SAFE course for the ICU Fellowship Exam preparation. My name is Josh Pillemer and I passed the exam in the second sitting of 2016, having attended the SAFE course earlier that year. This is the first section of a two-part presentation where we'll discuss the liver, spleen and kidney. The next presentation will focus on the pancreas, bowel and abdominal bleeding. Before continuing, I'd suggest viewing this talk in full screen at the highest quality you can. There's going to be a lot of images and usually multiple images per screen. I feel obliged to preface these talks by disclosing that I have no particular expertise or special interest in imaging, especially not of the abdomen. All we're trying to accomplish here is to try and tick off a bunch of the big ticket items that you'll be expected to identify in the exam. Purely from the exam perspective, abdominal imaging is likely to appear in two main places. Firstly, it'll almost certainly form part of the radiology station in the vivas, with one or two cases, probably CTs, containing 10 to 20 slices each, where you'll be expected to identify the main abnormalities and suggest possible diagnoses. The other place you're likely to encounter abdominal imaging is during the hot case discussion, if there's something relevant to the patient that you've just examined. I don't think it's controversial to say that trying to report these scans like a radiologist is not going to be the best use of your time. My tip would be to go straight for the main abnormalities because that's where the money is and your time is short. So how to best prepare? Well, it's like every other aspect of the fellowship exam. If you've done it 1,000 times before, it'll be noticed on the day and you'll be fine. So look at as many scans as you possibly can in the context of your clinical work. Don't just wait for the report, look for yourself and then use the report to see what you missed with your less trained eye. Go to radiology meetings if your unit is lucky enough to have them and pay attention. Ask the experts what you should be looking for and then look for it on your next scan. Again, as with the rest of the exam, it's a lot of time consuming work, but it's the sort of thing that will improve your practice as an intensivist, not just get you through the exam. Finally, I have to point out how fantastic a resource radiopedia.org is. Pretty much all the images from this talk have been sourced from there, and every year it seems to get more and more a complete resource. When it comes to practicing quickfire chest x-rays and brain CTs, I'm not aware of a more substantial online resource, so go check it out when you get the time. So with the sermonizing done, let's have a look at some of the major pathologies you'll be expected to encounter in the exam. We'll approach this organ by organ to be as systematic as possible. We're going to look mostly at CTs with just a few other modalities thrown in. So let's start with the liver and a quick summary of the various anatomical segments. Now, if you're like me, this sort of diagram will send shivers down your spine. Anatomy strikes again. I've got to say that knowing the distribution of the segments isn't crucial for the exam, but I thought I'd at least share a few things that I, possibly embarrassingly, only learnt while I was studying for the second part. The clockwise numbering system probably won't be news for many, but for me, I never knew the significance of the segments or how to place them in the setting of a CT scan. In terms of the significance, the segments form 8 independent functional units. That is, each segment has its own blood supply, both arterial and portal, and its own biliary and lymphatic drainage. In terms of their location on CT, what I hadn't realised was that the divisions for the segments are actually landmarks that are pretty easy to identify. Let's start with the horizontal split that separates the upper and lower segments. This line is determined by the horizontal line through the liver at the point that the portal vein bifurcates. Above the bifurcation, it's the superior segments, below the inferior segments. So that's the first landmark, the bifurcation of the portal vein. All that's left is these vertical dividers. Now, these arise as a result of the course of 3 hepatic veins, the right hepatic vein, the middle hepatic vein, and the left hepatic vein. Simple. So let's have a look at this on an annotated CT image. So here we have an axial slice just below the bifurcation of the portal vein. So you can see the right portal vein here. And as the schematic on the left shows, we're sitting at a point just below the bifurcation. And just ignore the color schemes as they don't match up. They're from different resources. Now, since we are below the bifurcation, we've got to be looking at segments 3, 4B, 5, and 6. And as you can see them presented across the image, you can see them here. Now, next we see the right, middle, and unfortunately you can't see where the left hepatic vein would be, but you can certainly appreciate it in more superior slices than this. Now, these hepatic veins are what divides 3 from 4, 4 from 5, and 5 from 6. Now let's just pop above the bifurcation, and in the next few images we're just going to pop above and below. And popping just above, you can see that it really is quite simple. 6 has become 7, 5 has become 8, and so on. Now in the next few slides we're just going to pop up and down just to clarify that you can see that this is the bifurcation. So in this image you can clearly see the left portal vein, and as we go up and down you can see that this is the bifurcation. Now, in considering pathology of the liver, let's start with the best exam fodder, which is trauma. I think it's a bit much to expect candidates to have a detailed knowledge of the grading system for hepatic trauma, as the rules are fairly complicated, but you'd certainly be expected to know that there is a grading system that goes from 1 to 6, and you'd also be expected to be able to describe liver lacerations, subcapsular and intraparenchymal hematomas, or major vascular injuries. Here are the criteria for grade 1 to 3 injuries, with criteria separated for hematomas on the left and lacerations on the right, with increasing severity of injury going from top to bottom. Now, probably the easiest rule to remember is regarding lacerations, where the only thing you need to remember are the numbers 1 and 3. So lacerations less than a centimetre are grade 1 injuries, lacerations between 1 and 3 centimetres are grade 2 injuries, and a laceration that's larger than or goes deeper than 3 centimetres is a grade 3 injury. Now this is made even easier by the fact that these numbers are exactly the same as they are for the spleen. Now here are the criteria for grade 4 to 6 injuries, which are certainly far more severe injuries. And these injuries relate to lacerations that are either much larger or more central in involving the vasculature. So let's consider an example. This is a scan of a young child who's fallen from a height with right flank pain. Clearly it's a very abnormal scan, but what I want you to do is to pause the presentation if you want and have a decent look at this series of just 4 images, and then have a go at presenting your findings, particularly with regard to the grade. My spiel would be something like this. There are 2 striking abnormalities in this scan. Firstly, there are multiple lacerations of the inferior aspect of the right lobe of the liver, which certainly extend more than 3 centimetres deep. Secondly, there's a large intraparenchymal hematoma, which is just inside the inferior aspect of the capsule, and I'd be interested in knowing what its dimensions are. I believe this represents a serious liver injury, likely grade 3 or 4, based on these findings. Now technically this is probably a grade 3 injury, but I think it's pretty irrelevant. The main thing is to show that you can demonstrate the major abnormalities and use your intuition to guide how serious an injury it actually is. Let's consider another case, this time a middle-aged man who suffered blunt abdominal trauma and is now shocked in ED. Pause the presentation to take a few moments to look at this sequence of 4 images and then present your findings. And this is something like what I would say. There's a large laceration involving both the left and right lobes of the liver, and although this series of images is limited to the superior aspect of the liver, there are certainly enough findings to suggest that this is a very high-grade laceration. If we follow the IVC down from the right atrium into the liver, then we can see that in the second image, that the laceration certainly involves the hepatic portion of the IVC. The laceration also involves the left portal vein, as seen in the 4th image. So given the extent of vascular involvement, this likely represents a grade 5 liver laceration. There's also a significant volume of blood seen around the liver and spleen, likely representing hemoperitoneum. Okay, let's move on to some more quick fire slides with different pathologies of the liver, starting with biliary obstruction. Again, pause the presentation to take some time to look at these images, highlighting the important findings. You know we're looking at biliary obstruction, so see if you can find what you expect to. So first, we can see dilation of the intrahepatic and extrahepatic bile ducts. The blue arrows highlight the intrahepatic bile ducts, which are dilated more than the usual 2 millimeters. The red arrows show the extrahepatic bile ducts, with the common hepatic bile duct seen in the second image, and the common bile duct in cross-section in the third image. These are both dilated more than the usual 6 millimeters. In the third image, you'll also note evidence of cholelithiasis, and in the final image, you'll also see a hyperlucency in the common bile duct, representing an obstructing stone and explaining all of these findings. Acute cholecystitis is very common and can be calculous or acalculous. On the left is an example of calculous cholecystitis, and on the right is an image of acalculous. On CT, the classic features are gallbladder wall thickening, pericholecystic fluid, a stone, which can be either obstructing or non-obstructing in the setting of calculous cholecystitis, and possible increased density cholecystic fluid as seen in this example of acalculous cholecystitis. These findings can be similarly found on ultrasound as demonstrated in this case. Again, gallbladder wall thickening here, which extends over 9 millimeters, and pericholecystic fluid are the main features. Another feature to mention is emphysematous cholecystitis, characterized by air in the gallbladder wall, which is clearly evident in both of these two cases. The case on the left actually had localized gallbladder perforation, characterized by air seen outside the gallbladder wall, local to the gallbladder. That's a bit tricky to see in this axial slice, but this sagittal slice clearly shows gas tracking into the subhepatic space and outside the gallbladder wall. The case on the right also had a gallbladder perforation, but this time the perforation has resulted in pneumoperitoneum, with gas seen quite remotely from the gallbladder. Air within the biliary tree is also worth making note of, being a relatively common sign, usually as a result of biliary instrumentation, such as ERCP with or without sphincterotomy, cholangiography, or a Whipple's procedure or any other type of choledochoenterostomy. It can more rarely occur as a result of infection, such as cholangitis or emphysematous cholecystitis. Pneumobilia is usually most prominent in the central larger ducts, as the flow of bile is from peripheral to central and it pushes the gas towards the hilum. That can be seen in this series of images with predominantly left-sided gas, which has occurred following ERCP. This is the opposite of the appearance of portal venous gas, where gas is usually seen in the more peripheral vessels due to the usual hepatopetal blood flow away from the hilum. This can be seen particularly in the image on the left. Portal venous gas can have many causes of highly variable prognostic significance. More concerning causes include bowel ischemia and intra-abdominal sepsis, while more benign causes include bowel lumen distension from endoscopy or ileus. The image on the right shows a large volume of gas throughout the entirety of the hepatic portal venous system as a result of mesenteric ischemia. This sagittal slice of the same scan makes the diagnosis quite significantly easier to see. Remaining with the portal vein for one more slide, another important finding to mention is portal vein thrombus, which can be a complication of many disease processes. Portal vein thrombus is best seen on the portal venous phase of a contrast CT, and this case shows a clear filling defect of the main portal vein extending into the left portal vein. And in the second image, you can see that the right portal vein is really quite free of thrombus entirely and fills quite well. In this case, this has arisen in the context of pancreatitis, where the last two images show evidence of pancreatic edema and stranding. Now, I'm trying not to focus on pathology in these slides, but portal vein thrombus, if you do see it, is one of those things that's really quite useful to have an approach for. And the easiest way for me was to approach it from the perspective of Virchow's triad and try and relate it back to the liver. So disorders of reduced blood flow as occur in cirrhosis and portal hypertension, disorders of endothelial injury as occurs in infection or inflammation, so pancreatitis, cholangitis, and hypercoagulability, which is, as per usual, primary prothrombotic states or any of the secondary conditions such as malignancy, trauma, pregnancy, and so on. Let's move away from the liver for now and move on to the spleen. Again, like the liver, the most exam relevant consideration for the spleen is trauma. The grading system for splenic trauma is similar to that of the liver, but again, you won't be expected to know the complete details. The key elements are grading from 1 to 5, with 1 to 3 involving lacerations and hematomas of certain sizes, grade 4 relating to lacerations that involve segmental or hilar vessels, and grade 5 describing either a shattered or completely devascularized spleen. This slide shows the requirements for injuries graded 1 to 3, and as we said before with the liver, down the right side of the screen are the lacerations, which have the exact same criteria as they did for the liver, remembering the dividers of 1 centimetre and 3 centimetre. Here are the criteria for grade 4 and 5 injuries relating to the degree of hilar vascular involvement. Of interest, the American Association for the Surgery of Trauma, or the AAST guidelines, also list shattered spleen as a grade 5 injury, which isn't listed here. We have 2 examples to consider here. So for each one, pause to spend some time inspecting the images and then determine the grade of injury. Now, from the available images from this first example of a 25-year-old man with blunt chest trauma, it doesn't look like there's any hilar vascular involvement, meaning that the grade must be between 1 and 3. The last 2 images show lacerations that certainly extend beyond 3 centimetres in depth, and that makes this a grade 3 injury. Again, pause to have a look at these images to determine the grade of injury. And from this injury, you can see that the hilar vessels, although they still look intact from what we can see in these 4 slices, there's very little remaining normal parenchyma, with active hemorrhage seen throughout most of these images. This is what we'd call a shattered spleen, and that represents a grade 5 injury. Now, we're not going to dwell on the spleen any further, but we'll continue the trauma grading theme by moving on to the last of the commonly referenced AAST graded organs, and that's the kidneys. Again, we've got a grading system from 1 to 5, where 4 and 5 represent serious injury. Grades 1 to 3 involve lacerations and hematomas, with the crucial elements being no collecting system or renal pelvis involvement. Any injury that involves these is at least a grade 4 injury. And as far as differentiating between grades 4 and 5, that's probably not going to be expected of you, but here are the criteria anyway. Safe to say, if you can't recognize any normal renal parenchyma, or if an entire kidney does not enhance, then you're probably dealing with a grade 5 injury. Consider this example of traumatic renal injury where no laceration or hematoma is evident on this slice. The complete non-enhancement of the left kidney here would be in keeping with a grade 5 injury by virtue of its evident devascularization. Another common finding on CT scans is renal tract obstruction. Hydronephrosis is evident from dilation of the renal pelvis or calyces, as demonstrated in this quite severe example. Hydroureter will occur down to the level of obstruction. In this case, there is clear dilation of the renal pelvis on the right, with a dilated ureter shown down to the level of an obstructing stone, which can be seen in the 4th image. Below this level, as you can see in the 5th image, the ureter is barely appreciable at all, similar to the one on the left side. Now, any of these changes can be unilateral or bilateral and can arise from a multitude of causes. In the exam, look out for stones and masses to explain them. Pyelonephritis is another condition that's worth learning how to identify on CT. And this example shows the classic features of pyelonephritis, namely a swollen kidney with diffuse lower attenuation. Note the comparatively larger right kidney with its darker appearance. Now that concludes the first part of this presentation, so please join me for part 2 when you've got the energy. Good luck.